Dancing. There we go. All right, welcome everyone to the June surveillance session of VLC, Building Longitudinal Databases and Registries and Development of HCV Cascades of Care, made possible in partnership with the CDC's Division of Viral Hepatitis. My name is Isabel Lechuga. I use she, ella pronouns, and I am part of the hepatitis team here at NASTAD. So joining us today, very exciting, is the moderator of the session, Danica Kuncio, who is a member of NASTAD's HepTAC Advisory Committee. And then let me know, do I have a microphone issue? Zoom is telling me I have a microphone issue. No, perfect, awesome. Okay, Danica is a viral hepatitis program manager at the Philadelphia Department of Health. We will hear today from our colleagues from New Jersey, Bernice Carr, Epidemiologist, Hepatitis C, and Mojisola Ojo, Epidemiologist, Data Coordinator with the Communicable Disease Service at the New Jersey Department of Health, and Kaitlyn Probst, Statistical Analyst for the STI HIV Viral Hepatitis Office at the Colorado Department of Public Health and Environment. And to do some level setting, I'm actually going to get us started by turning it over to Danica. Before I do, please know participants are placed on mute as they join, really for optimal audio, but please use the chat box to introduce yourselves and your jurisdiction and to ask questions. So with that, I'm gonna turn it over to Danica.
Hi, everyone. Thanks for joining today. Hopefully this will be an exciting Wednesday afternoon conversation. I'm really excited to hear from our two presenters, our three presenters, but two sites. But we thought that it might be helpful to just kind of level set a little bit when talking about longitudinal databases and viral hepatitis. So I figured I would briefly speak and just share some things to think about. This is by no means an exhaustive conversation, just some points to be keeping in mind, and then some grantee context, which I know is critical for all of us right now. Next slide, please, Isabel. So I think importantly, it's good to think about why are we talking about longitudinal databases. We are tasked with two chronic diseases, or sometimes chronic diseases, with hepatitis B and C in our activities, and testing can go on for decades. I know in Philadelphia we have tests for folks going back into the 90s for hepatitis B in particular. And we just really want to be able to track all of that information in an optimal way. Really important also for case statusing. So for hepatitis B in particular, there is a time limit, with being able to confirm a case. So there's a 6-month interval that is necessary between positive surface antigens to confirm that a case is confirmed. And so with rolling years, it depends how your system might use it, but that consolidation is critical to be able to accurately count probable versus confirmed cases for Hep B. And then for Hep C, the RNA is necessary as well for confirmation. And I think everybody on this call probably knows the delays can be real when it comes to getting an RNA after an antibody. Hopefully those delays are decreasing with reflex testing, but they're still meaningful, and thinking in terms of consolidating cases as much as, or information as much as possible, is critical. And then continuums of care. So we're all working on elimination. We're all working on various activities that rely on continuums of care to inform our identification of barriers for folks progressing through and really receiving the treatment or cure or care that they need over time. So these are really important tools as we're all working on elimination as well. Next slide, please. So some considerations just to keep in mind, and some of these will be addressed by our presenters today. Thinking about negative laboratory reporting. Are all of them entered? Do they trigger new cases when they are put into the database, when they hit the back end through ELR or other methods? Are negative tests only added if there's an existing case in place? it's important to consider how to navigate new labs in general, not just negatives. Does a case close after the original labs and a case is sent to CDC with its case status? Does it reopen for manual review? Do you do all your case statusing in staff? So these are all some things to think about and some aspects that need to be addressed when making a longitudinal database. And then data collection at multiple time points can occur. Question packages should be able to accommodate acute, chronic, potentially perinatal, if it's a person who is able to become pregnant, and then cure, and then reinfection, which I didn't have on here, but is a hot topic for sure. So these are all things that should be considered when creating your database. Next slide. And then deduplication, which gets its own slide because it's really complicated and I will be a large part of this conversation today. But just thinking about deduplication at multiple levels. We all know lab level dedupe is necessary. With ELR, sometimes you get the same reports multiple days in a row from large reference laboratories. So is your system able to address that? Thinking about deduping at the person level. So keeping in mind aliases, name changes related to marriage, using preferred names of people who may not be using their birth names. These are all things that can play into person level deduplication as well as our important points for many of the populations that we are serving with our viral hepatitis work. And then sometimes the case level in terms of deduplication, this varies between jurisdictions, I know, and so it's certainly an important topic to be considering. Do you change a case status or not? If they are acute confirmed, do they ever go to chronic confirmed? Do you have multiple cases and have an acute case and then a chronic case? I could have made a visual for this, but acute cases, chronic cases, if they start off as a perinatal case, do you have that separated as well? A vertical transmission status for a pregnant parent or postpartum parent. So these are all considerations, or do you lump it all in one and have one instance for hepatitis B and one instance for hepatitis C that can go through these dynamic changes throughout the course of a person's interaction with the surveillance systems. Next. Oh, and I don't have answers to a lot of these. I think these are important things for everybody to consider, and everybody's data system is different. We are, by nature, unfortunately, in our surveillance programming, not equipped to overhaul and pay for new data systems. So we have to adapt as much as we can. So I think there are solutions regardless of what you work with, but these are all just considerations more broadly for us all to have to think about in this work. And we are tasked with thinking about this by CDC with our 2103 grant. And so I just wanted to include these here, and then they're just to be on everybody's mind, places where this important work plays into our funding. So overall, we're just all tasked with improving monitoring of acute, chronic, perinatal Hep A, B, and C trends. And so the longitudinal database is just integral in this work. The strategies to jurisdictions without existing registries, should create them to avoid duplication of cases and to monitor continuums of cure. And so that shakes out in the outcomes that we're tasked to look at. Some of the last one, improved development and utilization of surveillance data reports, comes out of that and is an intermediate outcome. I think that means it's year 4 and 5 for the grant. So just something to consider going forward. And I believe Isabel can share these after, since I did all the legwork. Next slide, please. And last one, I promise. So then there's just also for us all to be aware in case DVH gets flushed with funds and are able to support some of our additional activities. These are the contingent on funding activities that play into the longitudinal databases and continuums of care. And so I wanted to make sure these are on there as well. I put on the perinatal aspects and ensuring that chronic Hep B is a part of your system as well. I think that's all I've got. Isabel, I think that's the last one. And now, really excited to have our presenters share their experiences with their site. So Bernice, I think you're first, is that right?
Yes, correct. Let me share my screen. Can everyone see my screen?
Yes.
Yeah, great, thank you. Hello, good afternoon. Again, my name is Bernice Carr, and I am the epidemiologist, the hepatitis C epidemiologist in New Jersey Department of Health. Today, we are going to talk about the management of hepatitis C cases in New Jersey Department of Health. I say we because I also am accompanied by Mojisola Ojo. So just a quick overview of the presentation. We will provide a snapshot of New Jersey. We'll talk about the burden of hepatitis C in New Jersey. We'll talk about our surveillance system, as well as how hepatitis C is managed in our surveillance system. We'll talk about data management altogether. We'll discuss manual duplication using LINK+. We'll talk about the benefits and limitations of LINK+, as well as discuss an alternative system for the duplication of cases. So just a quick snapshot of New Jersey. New Jersey is located between Pennsylvania and New York, and we is the most densely populated state in the United States, population of about 9 million people. 22% are foreign born. New Jersey is the second highest state for foreign born. So 21 counties make up New Jersey. The capital is Trenton, and most people live close to the metropolitan cities and the Jersey Shore. That's important information as we talk about the burden of hepatitis C. So as we talk about the burden of hepatitis C in New Jersey, both hepatitis C acute, chronic, and perinatal are reportable in New Jersey. Every year, we receive about 9,000 reports for hepatitis C. However, after cleaning, removing duplicates, etc., our overall total of reported case, what we report to CDC is about 6,000, between 6,000, sometimes over 7,000 cases. We have seen a slight decrease in the number of reports started in 2019 and continued through 2021. The new reports, as this chart shows, are primarily existing among multiple generations, with a peak at about 25 years of age and 60 years of age. Just to add, for acute, the primary age group for acute cases is 25 years old, whereas for chronic, it exists in both the 25 years old and 60 years old. We have the peak. So this chart is primarily just showing the overall age group that the cases exist for both acute and chronic hepatitis C in New Jersey, and is overshadowed by the chronic cases. Most of our cases are present in male species, and as the map shows, the highest rate of cases are in Burlington, Essex, Hudson, Passaic area, Atlantic Ocean, and as mentioned before, these are the most populated areas in the state. So in New Jersey, the system, the official disease surveillance system is CDRSS. CDRSS receives over 100 reportable and non-reportable and also work-related conditions. It is an integrated electronic lab reporting system that is patient-centric and web-based. It has advanced tools for data analysis, visualization, mapping, and reportable and exportable reports. CDRSS has the capacity to manage outbreak investigations, as well as provide schools and other facilities surveillance. It is structured to accept both positive and non-positive reports according to case definition by disease. It is industry standard security. It has industry standard security features. So just a quick overview of hepatitis C and how it is reported in CDRSS. So at least 90% of hepatitis C labs are reported electronically in CDRSS. However, a few lab reports are reported via paper reports, and these are mainly from jurisdictions that are out of state. HCV investigators at the local health department level provide updates on HCV reports for residents in their jurisdictions in CDRSS. So the local health department investigators, they have access to CDRSS and by law are responsible for investigating hepatitis C cases. There are multiple person and case merges per year that are not automatically identified by CDRSS. In 2021, we manually merged more than 2,000 hepatitis C cases in CDRSS. So in regards to data management and the hepatitis C registry, as part of the grant requirement, we know that overall data quality is essential to maintain the HCV registry and avoid duplication of cases. So as Danica mentioned earlier, this is part of component 1 in the work plan for 2103. And so in recognizing that, we used a new process to deduplicate cases. Moreover, removing duplication of cases maximize data quality and is essential to focus on putting together a jurisdictional laboratory-based cascade for hepatitis and to monitor the continuum of care efforts. In New Jersey, we are currently working on putting a laboratory-based care cascade together. And so in the last few months, we have been spending a lot of time deduplicating cases to improve the data quality of these cases as we work towards putting the laboratory-based care cascade together. The CDRSS has the capacity to capture negative lab reports, as mentioned before, and therefore that this increases the need for deduplication. So sometimes new cases are triggered from reports if the demographics do not match one-to-one in CDRSS. Also name changes and so on, as Danica alluded to earlier. And we also expect an increase in reports as more laboratories increase hepatitis C RNA reflex to testing, and therefore we expect to have more duplicates of cases. As part of our workflow, we run our deduplication program quarterly to reduce incidence of duplicates. The manual process in CDRSS we manually process, we manually merge cases in CDRSS when the demographics are not matched one-to-one, as I mentioned earlier, and the overall deduplication process takes about 2.5 hours per week. So now I will turn on to Moji to provide more of the technical details involved in the process of merging cases in CDRSS, in particular hepatitis C cases.
Thanks, Bernice. And I'll share my screen so I can advance the slides from here. Can you see my screen now? Great. So as Bernice mentioned before, my name is Mojisola Ojo. I'm an epidemiologist with the Communicable Disease Service in New Jersey Department of Health, and I coordinate data for CDS. So I'm going to be speaking about data management in CDRSS and also using LinkPlus. So from my screen over here, oops, I'm sorry, I dropped something. So from the screen here, I'm going to be talking about data management. As Bernice mentioned earlier, CDRSS is a patient-centric system that is state-developed. In other words, we developed it in New Jersey. The system is designed to incorporate this patient-centric model for all incoming lab report, whether the lab report is coming in by electronic lab reporting or is coming in as manual entry. Every disease and condition that's housed in CDRSS has its own specific algorithms, and this aids the case definition and concepts that come along with each disease profile. So is the case a new case? Is it a reinfection? Is it a probable case? Is it a confirmed case? CDRSS has the capacity to handle all different scenarios. It will also determine if the case is a negative test, and we can categorize it as not a case, but all of this is, the system has the ability to handle these different profiles. So take, for instance, Elizabeth O'Sullivan on the top right-hand corner of the slide, that's born in date of birth 12/1/1999. It's a fictional patient with the lab ID, the patient ID of 54789. She's a patient in the system, and with a patient-centric model, we're able to have the system that has all the diseases that Elizabeth O'Sullivan tested for, whether positive or negative, depending on the algorithm of the disease. So if she tested for these multiple diseases, you have hepatitis C, influenza, B0, lead, or coronavirus, all the cases that were reported under her profile would show up under her patient ID. This is the tenet of a patient-centric system. And it's very important because it allows us to be able to manage from a person perspective, as opposed from a disease perspective or case level perspective. We're starting from the persons. But how do duplicates get into the system? Mostly from data errors. Data errors can come in by ELR2 as well, but the system is designed to identify if a lab report is duplicate, that would be automatically kicked out of the system as the lab report comes in. But if the demographics, there are discrepancies in the demographics, take for instance a fictional Elizabeth O'Sullivan, whose name can be Elizabeth O'Sullivan when she tests for B0, but she tested for influenza last year and they spelled her name with an S, or they misspelled her date of birth. That basically would introduce into the system because the ELR or the deduplication automatic system would be matching one-to-one. So if there's a discrepancy in the demographics, it will create another person ID, and that brings in duplicates in the system. Now we have a process where you can do a system merge, but that's a one-to-one merge where every demographic profile comes in. We do have, when you create cases manually, you can create somebody with the same profile, and that's manual entry errors. But we could do a system merge that goes one-to-one on demographics. But what happens when the demographic does not match? We have to do manual duplication. And we've come across this software, LinkPlus, that has helped us along the process. So I'm going to talk about manual deduplication using this LinkPlus software. LinkPlus is a CDC software that was originally designed under the Registry Plus softwares for cancer record matching and deduplication tools for cancer registries. It computes probabilistic record linkages and matches, and it has the capacity to detect duplicates or match persons using two phonetic code systems, SoundX and NYSIIS. The program works for a really large number of records with an upper limit of about 4.5 to 4.8 million records, and that is an incredibly large number of records. And it provides best match options for all potential data matches and duplicates based on a user-defined threshold or cutoff value. Best of all, LinkPlus is free. So what are the benefits and limitations of LINQ+? So some benefits. Even though it was designed specifically for a cancer registry, it can be used for any data. You can put it out, first name, last name, date of birth, that's all it needs, and it will find you your matches and duplicates. Another thing, the probabilistic match and computation systems is largely hidden from the user. The system has default values provided for deduplication and matching efforts. It has a help menu and test examples that will assist users. The outputs are clear and accessible to new or advanced users. Best of all, like the ad says, it's free for free, for free, for free, for free. You cannot say this too many times. Some limitations. You have to create an external data file to be imported into the software for your matching or deduplication. The default values from the system may need to be changed multiple times to be adjusted to what it is that you need to deduplicate or match. When you identify deduplicates, you have to go back into the system and do a manual review and merge at that point, but it's helping you identify the work that needs to be done. So just a little overview of the process. It's really, really easy to use. You select the data file, import it into the system, do block matching variables, choose your phonetic system, click run, and the software will do the rest. There is a manual review process that allows you to manually review your matches or your duplicates in the software. You don't have to do that. You can go through and just output and start reviewing your data. Now, let me just show it in a pictorial display. This slide was used for LINQ+ presentation from CDC years ago. So imagine you have laundry, bunch of socks. If you had a system that can sort your socks out to match them, I mean, wouldn't that be perfect in a perfect world? This is what LINQ+ does. It would give you the high scores, the gray areas where you have sorts of matches, and then it will score the ones that do not match at all. So imagine if we had this in real life for laundry. I mean, life would be so much better for all of us, but this is what LINQ+ does. It basically helps you categorize your data and matches it based on different scoring systems. So what variables do you use? Demographic data, first name, last name, date of birth, social security number, middle name. We do not collect social security numbers in CDRSS, but you can use other matching variables like the zip code, generic ID, exact string data, or value specific data. All works, put it all in there. It would help you find your matches and duplicates. Now, this is an overlay of the system itself. It looks complicated, looks a little bit intimidating at first, but it's really simple. The top right-hand corner is a file for your deduplication. You put it in there. Here I have the Hep C data, and what I have in the variables are first name, last name, date of birth. These are my blocking and my matching variables in the system. You can put in other variables too as well, which will be the disease, the patient ID, case ID in our system, gender, county, municipality. You can even put address in there as well. You put it in as your other variables that would help you identify your matches or your duplicates. But the most important ones are your first name, last name, and date of birth. And literally, you click run because you have system default values that would allow you to run it without even adding anything else. When it's finished matching the process, you have this text box that comes up with how long it took you to match it and all of this, and then you can conduct a manual review and see what matched and change things. But if you don't want to, you can go straight to your output file. So this is your interface, but once you get used to it and you set it up, you can save your process and then use the same file and repeat the process as often as you need to deduplicate. This is what the output looks like. In the file that we sent in, we have our blocking variables, first name, last name, date of birth. In the matching parameters, it shows you the probabilistic data that we don't want to see, but it's there in the background, how much the data agrees or disagrees with the matching method, which we use, and the matching method that we use is a direct method. We had a cutoff value of 20. You can increase and decrease the cutoff value depending on how your matches are done. And the data is Below is the output in the system. So take Elizabeth O'Sullivan, for instance, that was a duplicate. In one of the cases that was sent in for Hep C chronic, she actually had a hyphen between the O and the Sullivan, and her first name was spelled with an S. This is a duplicate, and LinkPlus would find it. Same thing with other names like John Smith. The more variables you add in there, it allows you to a higher degree of matching or identification of duplicates. It gives us a score. Our cutoff point was 20, and it tells you what those paired matches cutoff point was. The match for John Smith, for instance, is 26.8, and then it stops at 20 with your data set. You can reduce or increase it depending on how fine you need to get the data points at. Sometimes you would get mismatched data when you use lower cutoff points, but it's best to start with the default values, and then you can adjust as you do your matching and deduplication process. So I'm going to quickly talk about an alternative system, which is MatchPro. MatchPro is a Java-based application developed by Information Management Systems for probabilistic linkages. It's based on the Vilangi and Santa model that LinkPlus is also based on. It's user-friendly with the interface and configuration linkages that can do manual review of certain and uncertain matches. It can run on a delimited data file with a fixed width. It can also run on XML and support XML files, which LinkPlus does not have the ability to. It's flexible. It allows you to filter incoming data, specify block matching processes, adjust weights, identify cutoff points, and you can do some, you can do review during the deduplication process. It also has a number of blocking strategies, but it has 9 distinct ones. Now, MatchPro or LinkPlus. MatchPro is actually more advanced than LinkPlus, and it can handle more parameters for complicated matching and deduplication. You have more tools during the manual review process, including a query editor. But the probabilistic math and computation is visible to the user during the duplication process, which could be intimidating and confusing if you do not know what you're doing, or if you're not an advanced data scientist. All that math is right in front of you when you're doing it, so it makes it a bit complicated. MatchPro has the ability to filter input files before the duplication process, so that's a great thing. It's also free, but it requires registration before download. But what we saw in our work is LinkPlus is easier to use for everyday work and for new users and people that are not advanced data scientists or people that do not have advanced data skills. It's more adaptable. LinkPlus is more adaptable for the everyday user. If you want more complicated things, yes, you can use MatchPro, but LinkPlus we were able to adapt LinkPlus for everyday use with all our data sets. So how do you get LinkPlus? Simply, download it from the Cancer Registry. It's an old software, but works very well up till today. Right now, it's at the 3.0. We were using 2.0 for a while, but 3.0 came out early, a couple of years ago. Oh, actually many years ago, but it's the same thing. It does the same thing, and it's very, very effective and efficient in your data management systems. Any questions?
I think we'll save questions for after Kaitlyn presents as well. But please do not hesitate to put any in the chat so that you don't forget, and we can, I'll make note of them and we can make sure that we cover them. So thank you, New Jersey. Kaitlyn, you want to take it over?
Sure. Okay, great. I think that everyone can see my slides, so I'll get going. Hi, everyone. My name is Kaitlyn Probst. My pronouns are she, her, hers, and I am a statistical analyst in the STI HIV Viral Hepatitis Office at the Colorado Department of Public Health and Environment, or CDPHE. And I'm going to go over how I developed the hepatitis C care cascade for Colorado. So a little summary, what I'm going to talk about, just a brief overview of the burden of viral hepatitis in Colorado, what's reportable in Colorado and how I use that in the development of our care cascade, and then finally, the limitations of the analysis and my conclusions. So to start, for a brief overview of Colorado, we're the 20th most populous state. We have a population of about 5.8 million people. In 2019, we had about 2,700 new diagnoses of chronic confirmed hepatitis C, making our rate per 100,000 population 46.6. As I alluded to, viral hepatitis lives within the STI, HIV, and viral hepatitis office. So just for a bit of background, here's how the staff breakdown works for viral hepatitis at CDPHE. So I am the only data analyst working with viral hepatitis data, and that's 20% of my job. The other 80% of my work does go towards STI and HIV. We have 2 full-time case ascertainment specialists. They do data entry and interviews. We have a full-time data entry specialist that solely does data entry for us. And then we have a full-time prevention coordinator. So a bit of background on our database and what it looks like. It's called the Colorado Electronic Disease Reporting System, or CDRSS. And this is a homegrown system, so we developed it in Colorado, and it's where all of our viral hepatitis data lives, as well as many other communicable conditions. It is an event-based database, so an individual will have a profile ID and potentially multiple event IDs corresponding to different diagnoses that they may have. So this is just a screenshot of one individual. You can see that they have the same profile ID, different event IDs for all of their different hepatitis diagnoses. And so each unique event ID then has other data that corresponds to that diagnosis that lives within other tables and CDRSS, including our lab data, which is very important for a care cascade. And then quickly, just some background on how we get our labs. Our case ascertainment lab team receives the labs through ELR primarily, and then also faxes. And they go through anywhere from 50 to 350 lab entries per day. And that's often with multiple labs per patient. And on top of that, they utilize other databases to correctly input a case based on that individual's particular circumstances. And then I'll talk about quarterly data cleaning on the next slide, but to implement those changes, our case ascertainment team, that takes about 1 month for them to do. So needless to say, they are rock stars over there. So a bit more of what I do to correctly present our surveillance data and correctly present our care cascade, give the best data quality that we can, is maintain our database. So a couple of things I look for are duplicate events, duplicate individuals, so deduplication like the last presentation. Also, I use our lab data to confirm the event status of a diagnosis. So many cases could be entered as a probable case, but then according to lab data, that case should be confirmed and vice versa. I also look for cases that should be deleted. Another big one is looking for missing or unknown lab results. So this screenshot to the right is a bit of our lab table. And you can see the test type is an HCV viral load quantitative test. And we do have a quantitative result, but that result text is unknown or missing. So we run into this a lot. And since I'm not the provider, I'm not going to make any assumptions. However, I do use this result text variable in my care cascade code. So I want that to be as clean as possible. So in this case, I would compile this list, send it to our case ascertainment team, and they would triple check that medical record to see if the provider did have a positive or negative result for any of these tests. And we try to get that variable as clean as we can. So this is an example of that result text when it is clean. So you can see there's a lot of tests here. We have an antibody test at the top, result text positive, great, that's clean. A lot of viral load quantitatives that are positive and negative. And then we also have a result date and collection date. And I use all of these variables to create the tables that result in my final database for our care cascade. And I do all of these cleaning processes quarterly. And this code took me roughly 8 hours to write over a week or 2. And we do this, quarterly to keep our data as clean as possible. So finally, getting into the care cascade. So as you saw in that last screenshot, the data that I have available to put into this care cascade are antibody tests and positive and negative RNA tests. The negative RNA test became reportable to CDPHE in 2019 after a Board of Health change. CDPHE employees really spearheaded this, I think, beginning in 2017 to get these negatives reported to us. And obviously this care cascade would not be possible without that. So I'm so happy that that change occurred. One limitation to this is that we don't get treatment data reported to us. So as most people on the call know, SVR12 is having a negative HCV RNA 12 weeks after completing treatment. And obviously we run into issues there if we don't have any treatment data reported to us. How could we know when 12 weeks after that is? So what we did is we used 2 negative HCV RNAs at least 3 months apart as a proxy for this because we don't get that treatment data. So I'll go into that a little bit more later. And then from a coding perspective, how I created these steps to the right goes like this. So I create a table for each stage of the cascade to the right with that unique identifier corresponding to that hepatitis diagnosis, the collection date of the lab test corresponding to that stage in the cascade, as well as the result of that lab test, which is why that result text variable is so important, that positive or negative. And then finally, I merge the tables on that unique ID corresponding to the Hep C diagnosis. So the result that I get is a wide data set with 1 row per diagnosis. I find this to be very easy, so you don't have to worry about duplicates, and it makes it really easy to do counts and percentages once you have your final data set. And then of course, I do this step by step to ensure that these tests do occur chronologically. I want to make sure that it's going in this order of positive to negative, and then potentially a reinfection. So first step, I find our first positive Hep C RNA and its collection date. So this code chunk below creates a data set with only positive viral tests. And I'm not going to show any more code chunks after this because they're pretty similar for each step in the cascade. But you can see that in this, I filter so the test type only includes viral tests, and that viremic test value is a string value that I set earlier in the code. And then I filter this last line so the result text does not equal negative. So again, result text is very important around here. And then the second step, I find the next 2 negative HCV RNAs. So again, because we don't have any treatment, I look for 2 negative HCV RNAs as a proxy for that time where a person would be ending their treatment. And then I create a new data set with those negative RNAs, merge them back with the unique ID, and then calculate the time between each of these tests. So this is a pretty busy screenshot. It's just 1 row of someone's data. So I highlighted the binary variables that I create so we can do those counts pretty easily in my final data set. So you can see that this person in particular did not have a positive antibody test reported to us, but that's fine because they have a confirmed case with us because they had their positive RNA. So they had their initial HCV RNA, and then they had the first negative HCV RNA. And then they had a second negative HCV RNA at least 3 months after their first, which would mean to us that they had achieved SVR. We had confirmed that they had achieved SVR. And then finally, from that group, I identify and look for reinfections. So that would be anyone that had a positive HCV RNA at least 6 months after their confirmed SVR. So with the reinfection, with how our database is set up, an individual will have the same profile ID and a different event ID for this unique diagnosis, or they should anyways. So this is the same person from the previous slide, and you can see that they did achieve SVR in 2019 for their first hepatitis C diagnosis. But then in 2021, they did have another HCV RNA reported to us that was positive, and that was 490 days after they had achieved SVR. So that by definition would be a reinfection. So after I create this data set, what I do is I export it and we visualize it in Tableau. So I'm going to show you a screenshot of our internal dashboard that we use to look at these data. So I didn't talk about antibody tests so much in our care cascade development. So the bar to the far left is a positive antibody test. It's lower because not all of our confirmed cases had one reported to us, but that's fine. When we publish these data, we don't include that because I find it to be kind of confusing if you don't really understand that you don't need an antibody test to have a confirmed case. Anyways, the second navy bar is any person that had a positive hepatitis C RNA. So like I said earlier, these are 2019 diagnoses. So we had just about 2,700 in 2019. And then the bar following that in the lighter blue is anyone with any negative viral load test that was reported to us. So you can see that's at 703 number, and that's 26% of our total diagnoses. And then anyone with a confirmed SVR, so having those 2 negative viral load tests at least 3 months apart, is the fourth bar, 264 people, and that was 9.8%. So because of the limitations that we have in our data, not knowing when someone ends treatment, we kind of look at this as a conservative versus a liberal estimate of who's been cured of their hepatitis C. So we know for sure that these 264 individuals have been cured of their hepatitis C because of the lab data that we had available to us. So we kind of look at it as 9.8% to 26.1%. Anywhere in between there are people that have been cured of their hepatitis C. Of course, having one negative HCV RNA does not prove that you have achieved SVR, but because of the limitations, we kind of look at it and interpret it in this way. For all of our published data, though, we only look at those confirmed SVRs. And then you can see we had 2 reinfections from our 2019 diagnoses. So many limitations to this, a lot I've touched on throughout my presentation, but one new one is that if someone moves outside of Colorado, we have no way of knowing this. So it's very possible that someone is pursuing treatment in a different state. And then similar to what I've been saying, if somebody doesn't pursue a negative HCV RNA after completing treatment, or if they don't have that initial one during their treatment course, we won't see those 2 labs if they don't get them because we don't get any treatment data. So that's why we do take into account this liberal and conservative estimate of our SVR, but then we only publish that confirmed SVR. Also, as of 2021, Colorado Medicaid no longer requires an RNA 4 weeks into an individual's treatment. So again, that means that many Medicaid clients may only have that 1 RNA reported to CDPHE, leaving those people in that box of only having that 1 test reported to us. So these limitations likely result in an underestimation of those that have been cured of their hepatitis C. And also because of that, it results in an underestimation of reinfections because we can't classify someone as a reinfection if we don't know that they've achieved SVR. So despite all of those limitations, I do think this analysis has helped us a lot to get a better idea of prevalence in Colorado. Additionally, even using our quote unquote liberal estimate of having that 1 negative HCV RNA, that's still only a quarter of our diagnoses from 2019 that have any negative RNAs reported to us. So it kind of shows us what's going on and who's pursuing treatment potentially. I did add this analysis to our annual surveillance report, which is published on our website. And it's broken out by certain reliable variables that most of our cases have pretty good data for, like sex, county of diagnosis, and age of diagnosis. And hopefully in the future, we can increase data sharing where possible to bolster this analysis. In my wildest dreams, we would get those treatment data reported to us. So this would be a little bit more reliable, but we'll see what happens with that. And then also in the future, I'd like to match with vital stats data because it's very possible that someone in this cohort has since died. And overall, this took me about 2 months to develop. And of course, I'm constantly updating it and trying to improve it as well. So that's all I have, but I just wanted to shout out 2 of my team members. First, Joaquin Herron, he's a case ascertainment specialist, and he helped me develop the slide on his work. And also Rob McGoy, who's our viral hepatitis prevention coordinator, who's just a wonderful thought partner for me working through this analysis. So that's all I have.
Thank you so much, Kaitlyn. I have many questions. That was really exciting to hear about all of your work. But I wanted to give folks the opportunity to ask any questions. As the beautiful slide says, you can insert them in the chat box or raise your hand. Don't all jump to it at once, but I'm sure this has been really stimulating for a lot of folks. I can get us warmed up a little bit if we want. So I think a question I have for both sites in terms of deduplication, what would you say is the biggest challenge you guys have had to overcome or still have to overcome in terms of really making sure that your person level databases are adequate for what you're planning on using them for?
Really? I could start. So one of the biggest challenge for us is generating the file for the dedup and then going back into the system to merge the cases. So this can be tedious, and especially since we did not have a good program such as Linkless prior to the end of last year, then we have to go back a number of years. And so our list of cases to deduplicate is very long. So it's getting shorter. The last one I ran 2 weeks ago was shorter, but still long. So it's a tedious process at first, but hopefully as we continue routinely, then the number of duplicates in our registry will reduce. We also have limited staff capacity to do routine data management. So that's our biggest challenge.
I would say in Colorado, how we have it set up right now puts a lot of burden on our case ascertainment team, because when I do find any duplicates or anything like that, they kind of have to do the manual side of it where they double check and make sure that everything lines up. So it's quick for me to run code, and then it adds a lot of work to their plate. So we're trying to do it more often so we catch up. But of course, I feel like we've been playing catch up ever since COVID. So we need to keep people's workloads manageable at the same time.
Yeah, I know that that's the same for a lot of jurisdictions, including ours, and I think including Rachel McLean from California as well. And she had a question for you, Kaitlyn, in the chat. She says, we get dozens of RNAs for the same person. How far back do you go to select your first RNA? Yeah, so I didn't mention this so much, but so we only look for the care cascade anyways. We only do diagnoses 2019 and forward, just because that's when we started to get our negatives. So I didn't want to look at anyone that had been diagnosed in like 2018 or anything and not have those negative HCV RNAs potentially have happened in 2018, and we wouldn't have that in our database. So we look at 2019 forward. So I do the first occurrence of a positive HCV RNA. So I filter to the very first one that they have. And then other like math procedures kind of happen later on to determine the first negative and then any negative that's within that time range I'm looking for. And another question for you, Kaitlyn, from Anne. Are you reading it? For everyone on the phone, Anne from Oregon, asking about multiple negatives and the point at which to which I alluded earlier, closing a case and then reopening it if they're a reinfection. I think this would be a question from both sites actually that would be interesting, is how do you handle cases once you case status something or somebody reaches cure? Are you closing it and then starting with a new case, or are you going to continue either with a reinfection or if it's been closed, reopening it then? So I can answer. So when someone has been cured, so when they have those two negative results, we close that case. Our case ascertainment does that. And then if a new positive comes in after the case has been closed, they open a new event for the same person as a new hepatitis C diagnosis. Is it the same for you all in New Jersey?
So each disease has its own algorithm. And the great thing about it is we're able to determine if it's a reinfection based on the algorithm attached to that disease profile. So if a case needs to be reopened with a new lab test coming in, it will reopen. And in other scenarios, if the case is a specific time point has passed by, it would generate a new case under the same person profile.
Makes sense. Jennifer has a follow-up. Oh, Kaitlyn answered Rachel's question, unless Rachel wants to come back with a response. But Jennifer asked about once a negative, once RNAs were reportable, was it difficult or easy to get labs to comply? This, I think, is the golden question for many jurisdictions. So how, if you are aware, if you were a part of that process, do you know how that worked?
So I wish I knew, I wish I could say more because I'm not sure. I think that would be a question for our case ascertainment people that were on staff in 2019 that were actually instigating those changes. I'm not sure if like Joaquin or Alicia Baca know if they can jump in. So I'm sorry, I'm not entirely sure on that one. Yeah, sorry about that.
if there is any jurisdiction where it was like a light switch, please, please, please share how you made that happen, because I know the rest of us would really be grateful for your sage wisdom. Okay, so Paula asked if when opening a new case, do you run into deduplication issues? I think in that reinfection instance.
Yes, it all depends on how the case comes into the system. So again, if it comes in by ELR and comes in the right manner, it would append to that same person ID. However, if it comes in by a manual entry and the person did not check in the system, if that person existed with other case profiles, there would be duplicates that are developed. And this is the reason why doing case management, it is very, very important to run this deduplication process. And in the same thing, handling whether it's a reinfection, acute, chronic, this is the reason why all these diseases have specific algorithms, but it's not foolproof because you do get duplicates in the system depending on how those labs are introduced into the system.
I just had another question, I think that is applicable to both jurisdictions, about any limitations in your processes that might be specific to special populations. Are there populations where Link Plus is not as ideal, or the database doesn't do a great job of the one-to-one matches? And then Kaitlyn, likewise for you, are there any populations where you've found that the 3 months, the repeat negative RNA isn't happening? And obviously you can't know what you don't know, but have you done any digging to see where there might be gaps?
So I'll take the first question. So we do have, when you do not have complete demographics for patients, we have populations like the homeless populations, transient populations, or people that live in shelters where demographic information is not complete. And in some instances, we do have received lab reports with incomplete profiles. So we use other systems like Rogers Claire to find a person and identify who the person is before we actually make the decision to merge a case if necessary. So Claire would tell us if the person was incarcerated, or give us details far back many years in terms of the person's demographic profiles or where the person lived over a period of time. So we use other systems to help us do with that. But yes, we do have problems with populations like the homeless and transient populations and people that live in shelters that we do not get complete demographic profiles on.
Yeah, I can say that Colorado in particular is a very rural state. So one thing that I noticed is just that a lot of folks that are living in more rural counties, so not in the Denver metro area, don't seem to reach a confirmed SVR as much. So that could either be that their provider is making it easier on them for not coming in for an additional test, or that they're not achieving SVR. So it's kind of just understanding what's going on in those situations and kind of making assumptions where we can. But yeah, it's interesting. And I think that we want to look into it in more depth for like our transient populations, people that are experiencing homelessness at the time of their diagnosis, and looking at that stratified by more variables for sure.
Thank you both. And I want to thank you and Bernice for your amazing presentations. This was a really exciting conversation, and I'm sure got a lot of folks the wheels in their head turning, and you'll probably receive outreach from people very inspired by your work. So thank you for your presentations. We encourage everybody to fill out the session evaluation. This is important for NASTAD to know how these sessions are working. And I know that you guys will be complimentary of these presentations, but hopefully they were useful for you as well. And they certainly were for me. So thanks everyone, and hopefully chat soon. Oh, and the next session is next week. It's not 2 weeks from now. Remember it. And then hopefully we'll all see each other at CSPE. Thanks, everyone. Have a great afternoon.